We're going to begin with Professor Naomi Zewde, who is an assistant professor in the Department of Health Policy and Management. Please welcome me in bringing on Professor Naomi Zewde.
Hi. Anyway, great to be here. I'm Naomi Zewde. I just started here at FSPH in September, and I'm really glad to be here. So I'm going to talk a little bit about equity and then finish off with some of my newer work. So basically, yes, as our moderator introduced, equity is a huge problem in the United States, and we're particularly bad about it in our healthcare system here. So low income, meaning below median households, nearly 40% of American households within 1 year avoid going to the doctor because of cost. And it's actually better to be lower income in these European countries than to be higher income in the US because it's so expensive. We spend a lot of money on healthcare, right? So the US is quite an outlier. This is as a percentage of GDP on the left. But however you measure it, we spend a lot more on healthcare. And yet we get a lot less for it. So we get less health, right? We're an outlier in the opposite direction in terms of life expectancy at birth, higher than average, chronic conditions. So we get less health. But we also get less health care. So we have fewer physician visits per capita, fewer physicians per capita. So many different measures. Shorter average length of stay in the hospital, conditional on diagnosis at admission. We have fewer hospital beds. We have a lower occupancy rate of those beds. So we use less care. We just spend more on it. So in economics, that's a problem. It's very inefficient. So usually we kind of get together every time there's a presidential election to talk about, what are we going to do about this problem? So the last, big push and big source of progress was the Affordable Care Act. So we reduced rates of uninsurance pretty substantially, almost by half. We did that through expanding private insurance through the non-group markets and expanding eligibility for public coverage in Medicaid. And each of those kind of had, their own issues that now the work is to improve upon. So in the non-group markets in the private insurance arm, we had just really high deductibles. So for, among people who were uninsured prior to the ACA, kind of that prime group of people we want to draw into coverage, it's cheaper to file for bankruptcy than to reach the deductible of the subsidized, benchmark tier of coverage for about 1 in 4 previously uninsured adults. So it didn't provide a lot of financial protection for this population. Medicaid, that's not the problem in Medicaid at all. We have a huge literature showing all of these downstream financial benefits to households from the expansion of Medicaid. Reductions in the rate of poverty, reductions in the rate of home evictions in the US. There's a lot of different indicators, but Medicaid has its own inefficiencies involved. So I think that Medicaid is doesn't have the presence in our public conversations that it probably should. It's a huge source of coverage, actually the biggest in the US. It's mainly administered by states, and the federal government chips in half. That half is the third largest federal domestic expenditure behind Medicare and Social Security. So it's a really big, important program. So most states administer this program by contracting with private insurers, about 72% of beneficiaries. So basically the state pays a per person per month fee to the insurer, who then acts like an insurer. They network providers, do prior authorizations, and they finance and deliver care. And the reasons behind it have never really been clear in the evidence. So if you look in legislative debates, so in North Carolina, they switched over very recently in 2021. They tend to cite fiscal savings, but most of the literature doesn't evidence that. And I would argue that that's because there's little room for consumer competition. I teach economics, if you haven't noticed. But the thing is, once the state chooses to contract with one of these insurers, they have to provide a basic package of benefits. It's a safety net program, right? So from consumers' perspective, there's not that much choice. So the setting of standards really has to happen at the state level. And so in order to do that, I think the first step is oversight and monitoring. And then the second step is, okay, where can we be better? And how do we inject some of that competition for firms to try to, have a reason to strive to do better as well? But that's really hard to do. So we've submitted some Freedom of Information Act requests recently. And I think this is the first place for us to move forward is basically, as it says, like in that purple box on the right, they just don't maintain this information regarding, how institutions allocate their funds across medical care and different administrative categories. So that's our first step for this year. But more generally, I think that, making progress on health equity in the US, it's really important for us to beef up our public systems because the fact is our public policies play a really important role in regulating and administering and financing healthcare. So this is work from Alice Chen and Emily Oster, but it shows that infant mortality is one area in which the US really lags behind peer nations. And you really see the biggest gap amongst, disadvantaged populations, so lower income households. So they are very much affected by, our progress towards equity. But in fact, even amongst higher income households in the US, so the top 1%, top 5% of counties frequently fare less well than average residents of other nations in OECD countries. So really beefing up our public systems and making that kind of progress in terms of equity and financing, to bring it back to the beginning, it's going to be better for all of us. Thanks.